So Emily and Lauren are two of my neuro PTs, and Jenny's neuro OT. And they're, I mean, they are really skilled women. I mean, they do cool, it's impressive. I've upped my game hanging out with them. You know, I'm classically trained as a neurologist, and I'm very interested in physiatry, and I read a lot about physiatry and try to...
So when I asked about physiatry today, you went into the physical therapy center, and I was actually asking about do you have a person that directs where all the patient's care is to be? Isn't that a physiatrist?
Well, so a physiatrist can, particularly in an inpatient setting, direct inpatient PT, OT, all that kind of stuff. So Ohio Health is structured a little bit differently. A guy named Dave Rupp, who is he
was on your list that he was supposed to be here.
He was, but he had something I could. So he did he's an OT by training.
Okay.
He's an administrator, and he's in charge of all rehab. And so he directs how they do that. They have physiatrists, but they're private physiatrists, mostly do pain stuff.
So what is it then that he's a physiatrist and...
Well, so a physiatrist, a physical medicine rehabilitation doctor, is an interesting, relatively new field. And it's kind of borrowing small pieces from different fields and putting them together in a very functional way. And the best way to describe a physiatrist, in my opinion, is to think about function. So they're not a physiatrist isn't necessarily getting involved in like why you walk funny. They're just trying to make you not walk funny. And a lot of times they, particularly on the inpatient setting, they collaborate with a physical therapist, an occupational therapist, and a speech pathologist, and then they direct sort of what happens like during an acute rehab phase. So we at the MS Center recognize that function is very critical. And so we pretend to be physiatrists sometimes. And we work very carefully with our therapists trying to coordinate and manage care.
Is there anything that a patient needs that's not associated with your healthcare system that you have to send the patient out?
So urology is a very special field. And my favorite urologist in Central Ohio doesn't work at Ohio Health. And he's so good that I still send people to him because he's that good. You know, I'm very, very loyal to brilliant clinicians who take good care of my patients. And when I find one, I'm reluctant to let go. Now, we have urology, but we don't have his level of expertise. You know, in another area where we need more people, but that's not unique to Ohio Health, is psychiatry. There is a national shortage of psychiatrists. And so having a psychiatrist available would be a godsend. And right now we catch as catch can.
Do you have neuropsychologists on staff?
We have many neuropsychologists on staff. We have 4. Now they don't only work in the MS space, but they preferentially see our patients sometimes. And so we use neuropsychology quite heavily as we try to help people understand the landscape of cognition, identifying areas that they do better or worse, and then leveraging the good areas to manage the bad ones. That's a big part of trying to keep people in play.
Right. So what I was saying then about what you don't have at Ohio Health, but what do you have that, you know, why patients are so beneficial to go to Ohio Health and all that you do offer? Can you name the
yes.
fields?
I think I have to take a step back, though, and say that I think that the philosophy of how we take care of patients is unique. It's at least unique for my experience as a clinician. I've never been in an environment where there was a singular goal of helping patients do better, and that's the only goal. So, you know, we do clinical trial research. We have 6 up-running clinical trials right now, and we do education. We have a fellow, and we train residents. But that's not the focus. The focus is on an N of one person, and trying to make them and their family better. And I can't say enough about that. You know, after having been where I am now for a couple months, I came home and I said, honey, hundreds and hundreds of people can't fake nice forever. And it's just an unusually weird environment where if it's for the betterment of the patient, the answer is yes, what did you need? And that's magical. So that's really, in my opinion, what makes it awesome. Now we have at our disposal resources that patients need. So we have social workers that are trained in MS, that can do coordination of care, they can do counseling, they can come in a room, they can help you grieve. They're really very special people. We have neurophysical therapists, we have neurooccupational therapists, we have speech pathologists, we have registered dietitians, we have clinical trial coordinators certified, again, in multiple sclerosis to help our patients understand trials, or if they choose to participate, go through that process with them. we have infusion experts and infusion coordinators that help a patient navigate some of the very, very complex REMS programs for these various drugs and help get people through the insurance processes, which is very complex. And we have billers that will come and talk to patients. This is in addition to fellowship-trained MS doctors like myself and Dr. Nicholas, other wonderful doctors that do MS like Dr. Eubank. And we have nurse practitioners that only do multiple sclerosis. You know, sometimes when a patient meets me and I tell them that I alternate visits with my nurse practitioner, they give me a funny look and I say, Colleen has been doing only MS 4.5 days a week for like 7 years. She understands MS, quite frankly, better than most doctors do. And the only thing that happens when you see her is we have 15 extra minutes and she's much more pretty than I am. But you know, the level of care doesn't change. And in fact, I think seeing different providers, seeing a team enriches your experience. Because you may not feel comfortable talking to one person about one thing, but a different team member you do, and that's critically important. A couple other things that I think are very relevant at our center. I don't want to give you a drug and send you off to have it done. I want to do it under my observation. Right. And so we have a very large 12-bed infusion suite that I'm very proud of, and it's in our clinic. So I may see you once every 3 months, but if you're there, for example, a monthly infusion, I'll walk by and see and we can talk. And if we need to do something, we can. We have 3 Tesla Siemens MRIs.
That's what I was going to ask you about next. The Tesla unit that you use, the magnification, is it mag?
It's the strength
magnetic,
of the magnet.
Right.
And we use a Siemens 3 Tesla MRI, which is kind of like saying I've got a jet fighter plane, you know, available. And the quality of the images that we have is really unprecedented.
How do you match that up to a patient's MRI a new patient that got a 1.5 scan from somewhere else? How do you now match up the apple with the orange?
So there's been studies that demonstrate that on a 3 Tesla, you pick up more, you can see more than on a 1.5. And so you have to be savvy and you look at it and you say, look, I'm seeing new things here, I think, but because there's differences in scanner strength or technique, we might not be able to make that comparison. And we may need to just be honest and say, I'm concerned there's new spots, but I can't confirm it. We're going to get another scan in 3 or 6 months, and that'll help guide us. You know, the other thing about the scanner that I'm very excited about was we have adopted the internationally accepted CMSC protocol. We do 3mm cuts with no gap. We have a 5-minute delay before we give GAD, for example. And these really result in very, very crisp, clear scans. And we have developed a relationship with a company that allows us to do a volumetric analysis on scans. This is a project that we're getting ready to launch. We've gone through an amazing journey with IT, and we're at the point now where very soon we can order what's called NeuroQuant.
NeuroQuant.
NeuroQuant is, you get an MRI, and the experience is the same as your last MRI. But there are certain sequences which are sent to this computer, and they calculate automated gray matter volume, white matter volume, ventricular volume, and whole brain volume. And it can accurately identify atrophy. So brain atrophy, we know, is a critically important marker in MS. But on a conventional scan, you can't really measure it. You can eyeball it, but you can't really measure it carefully.
Can you see more black holes with the 3 Tesla?
You can. Everything's cleaner. Everything's more notable. And so when I take a picture of the holiest of holies, your brain, I tell people, I don't want a TV like my grandma's. She had this giant black and white TV that was encased in wood and had an antenna. And if you're watching OSU football, you're not really sure which team's running the ball. You can't really tell. I want a plasma screen, high definition TV like at VW3s, you know, where you can see the sweat running down the guy's cheek. That's the level of detail that you and I need if we're going to critically look at your noggin. And so I think it's relevant. Now, the rubber meets the road when you got to pay for a scan. And scans are expensive. And so, you know, we talk a lot about assistance programs within our own healthcare system. We have charity care and HCAP care, and we leverage wonderful organizations like the MS Association of America that has programs to help patients get scans. It's that important.
Well, MS Views and News would like to thank you for everything that we've just spoken about.
You honor me.
And every patient should have a doctor like Dr. Boster, you know? That's the bottom line.
You honor me. Thank you.
You're welcome.
Thanks a lot for having us.